All right. Okay. Three after the hour, so I think we can go ahead and start. So, good morning, everyone. Happy Friday. Thank you so much for joining us for the last AI for Health Forum talk of this academic year. We are super excited today to have Danni Miltz from Emory talking about some updates about from the PRECISE trial, which if you were at the talk last year, Dr. Bhavani gave, and there was lots of interest and excitement. So we're super excited to have a return speaker. So Danni Miltz is a physician assistant at Emory Healthcare in the Surgical ICU. She's a member of Dr. Bhavani's lab and has been working on the PRECISE Precision Resuscitation with Crystalloids and Sepsis trial. For the trial, she focused mostly on the education for providers with the AI clinical decision support system, followed up with analysis for factors that affected the provider compliance with the CDSS. So we're super excited. As always, feel free to put questions in the Q&A as the talk goes on, but we'll save actually all that discussion for the end, which I'll moderate at the after sort of the main talk. So without further ado, Danni, take it away. Thank you so
Thank
much for
you.
being here.
Thank you. All right, so I'll start. So I'm going to talk today about our prospective study of factors associated with clinician compliance with the sepsis AI algorithm as a part of the PRECISE trial. And I have no disclosures. So first, I'm going to go over an overview for all of you who don't remember, but the PRECISE trial. This is our precision resuscitation with crystalloids and sepsis. And then next, I will discuss the sub-study of the PRECISE trial on factors affecting compliance with an AI clinical decision support system, which we call a CDS, which looks at the intersection of AI and the clinician implementation into practice. So to start, a little bit about IV fluids. IV fluids are the most common treatment given within the healthcare system each year, with over 30 million people receiving IV fluids in the US per year. And when it comes to IV fluids, there are two major choices. We can give balanced crystalloid or we can give normal saline. And after 14 RCTs, we still don't have a definitive answer on which fluids to give which patients. We identified a subgroup of septic patients that has a 15% mortality reduction from balanced crystalloids, which means for every 7 patients that receive balanced crystalloids in this group, we could prevent one death. So prior to the PRECISE trial, a sepsis trajectory model based on initial vital signs was developed. Patients with suspected infection admitted to Emory Healthcare, first between 2014 and 2017, were used as a training cohort for this model, followed by from 2018 to 2019, we did a validation cohort. Group trajectory modeling was applied to the initial vital signs in that first 8 hours of hospitalization to develop the trajectory subphenotypes. So patients with sepsis followed these 4 distinct patterns of vital signs. These 4 different subphenotypes had different mortality benefits from different IV fluids. This model was then tested as a secondary analysis to the SMART trial. And then you can see here in blue, that's a group D population. They had a significantly lower mortality when they received balanced crystalloid compared to normal saline. So group D had significantly lower temperature, heart rate, respiratory rate, and were overall more hypotensive compared to the other 3 groups. And this is just showing that 30-day mortality benefit for, again, the group in blue, which is group D, who when they receive balanced crystalloid. So for the PRECISE trial now, the EPIC algorithm identified patients with a suspicion of infection. This is done based on an order for blood cultures. And then if they fit into that group D population, they would automatically be enrolled into the trial into either the usual care or the intervention group. And the endpoint being 30-day mortality. So, if the patient was enrolled into the usual care group, the provider was blinded to the patient's study in the trial and received no alerts. If the patient was in the intervention group and the clinician ordered balanced crystalloid, there was also no notification of the patient's status in the trial. However, if the clinician ordered normal saline for a patient in the intervention group, they received an EHR alert, which we call a CDS, a Clinical Decision Support System, prompting them to consider balanced crystalloid. The trial started first with department education to the ED and the ICU. That's where the trial took place. And this was to our physicians and APPs in the form of we did a virtual training by department educate for the department education. And then we can continue that until June. At June, when we launched the Precise trial, we sent out initial email reminding people about the trial that was going to occur. We had to pause it in October of 2024, and that's due to the IV fluid shortage. We resumed in March of 2025. At that point, we had sent an email also reminding people about the trial. And then we completed enrollment in November of 2025. There were 2,012 patients enrolled across Emory Healthcare. We had 6 hospitals at that time, both tertiary and non-tertiary, all in the state of Georgia. So in order for the Precise trial to be successful, we had to have the clinicians accept the AI recommended CDS. We decided to do a sub-study to better understand compliance with the AI recommended CDS. We sought to determine if there were similar rates of compliance compared to a traditional CDS, and if factors associated with the traditional CDS also affected a CDS with an AI recommendation. So, a clinical decision support system, the CDS as we call it, are alerts that have long been embedded into the EHR system to influence clinicians' ordering practices. Examples of traditional CDS are alerts that make guideline recommendations. They can alert clinicians of drug-drug interactions. They can also do drug allergies, suggest alternative medications during shortages, or suggest reducing repeat orders. In previous studies, there has been a great heterogeneity in the compliance of CDS, but there are several studies that have demonstrated improved adherence to guidelines or decreased medication errors. In traditional CDS, the clinician understands the why behind the recommendation. That differs from an AI CDS, where the recommendation, the clinician is unaware of the algorithm, and therefore the CDS is considered a black box recommendation. We were concerned that this might affect clinicians' trust overall in our CDS, and that multiple studies we've seen have cited clinicians' skepticism of incorporating AI into their practice. So this is the CDS that clinicians received. So you can see this is in EPIC, so it's an LMA, which is an alternative alert, and it advised our clinician to consider balanced crystalloid instead of a normal saline. The alert is inserted directly into the workflow. So they would place an order for normal saline. They would receive this pop-up instead of getting the order for normal saline. And you can see here, it just says a potential mortality benefit. So they don't understand the algorithm that may have suggested this. And then there's the alternative. This is what we're suggesting them to choose. This is a balance, either for balanced crystalloid, either plasmolite or lactated ringer. And then they can continue with their order of normal saline. That's their bottom option. They can also remove order and just X out, and that would result in no IV fluids being given. And once they select one of these 3 options, it continues directly into their normal workflow, and there's no other pop-ups. So one of the first things we sought to do was how to define compliance using our AI CDS. And there was not great characterization of this in the literature, so we wanted to better understand both our compliant group, but also the non-compliance and all the pathways to get there. So first we had the alert response. So back to the alert that you just saw, they could accept it, they could cancel it, that's Xing it out, or continue with a normal saline order. So the most easy pathway to define, they accept the alert, they place an order for balanced crystalloid, and the patient receives balanced crystalloid. This is our only way of getting compliance. The other ways, so you could, for non-compliance, they could hit continue. This is for normal saline. The order was placed and the patient received normal saline. But then we had this group in between, the cancel, where they just X out and the patient didn't receive fluids. And then there are two other ways they could get there. They can initially accept the alert, or they can continue with a normal saline order. But then on the next, when the order popped up, they would X out and the patient didn't receive fluids. And to better characterize the interaction and the subsequent interactions with the alert, we measured compliance in two different ways. We did alert level compliance, which we defined as an interaction with every alert as an individual event. Order level, then we defined order level compliance, which was the interaction with the alert in a 15-minute window by a single clinician on a single patient. So just if you look at case one for compliance, this first time we had, and things like this actually happened when we were looking back. So someone placed an order for normal saline. They got the alert. They just X'd out of it immediately. They still wanted normal saline. So they ordered normal saline again. This time they accepted the recommendation, but for some reason X'd out of the actual order. They still wanted normal saline. They placed another order for normal saline. This time they continued with normal saline order, but for whatever reason, then X'd out of the order. And then finally, the last time they placed a final order for normal saline, they accepted the recommendation and the patient received balanced crystalloid. And so this all occurred within a 15-minute period. So for the alert level compliance, this is four alert level or different interactions. And we have three that were non-compliant, followed by one that was compliant. And then when we did it collapsed into that 15-minute window for an order level compliance, this would be one compliant event. Okay, so now to go over our results. We looked at the alert interactions at the system level, the provider level, and the patient level. So this is just how many alerts were fired in each group. So to start, for a setting, most of our alerts were fired in the ED compared to the ICU. When we looked at hospital type, tertiary and non-tertiary is pretty even split. At the provider level, most of the alerts were fired or received by physicians, then our APPs. Other was our nursing staff and our pharmacist. For shifts, it was a pretty even split between day shift and night shift. And then for the shortage period, most of our alerts actually were fired in the post-shortage period, almost double. And then for the patient level factors, we looked at race. Most of the alerts were fired on African Americans, followed by white. For sex, is a pretty even split between the two genders. For age, most of them were fired on our older population, greater than 65. And then these last three things, these were based on severity and abnormalities for the patient. So KDIGO score is a measure of kidney dysfunction. A score of 0 is no kidney dysfunction. A score of 3 is the highest kidney dysfunction. You can see most of our patients were that low to no kidney dysfunction. For sodium ranges, a normal sodium range is 135 to 145, and most of our patients that received the alert fell into that normal range. And then for SOFA scores, most of a SOFA score is organ dysfunction. A lower SOFA score has less organ dysfunction. So most of our patients fell in the lower organ dysfunction of less than 4, which was an indication of lower severity of disease. Next, we want to look at what was the most common interaction with the alert. And it actually, most people did, you can see in this left-hand column, that's accepting the alert. Most clinicians did accept the alert recommendation and place an order for balanced crystalloid. The box is everyone who's non-compliant based on our definition. So you can see the next most in the right-hand column, the right-hand bar, I should say, is canceled orders. So next, most commonly, they would just X out of the alert. And then followed by the third most common was to continue with normal saline. These two smaller bars, these represent the people who either placed and changed their order to balanced crystalloid or continued with normal saline but didn't ultimately place an order. Multiple factors at the hospital level, provider level, and patient level were all evaluated then using the chi-squared test. Overall, we found a compliance rate of 40%, with a moderate number of alerts being canceled at a little over 26%. At the hospital level compliance, the ED was significantly more compliant compared to our ICU colleagues, with 46 versus 17%. And there was no difference between tertiary and non-tertiary hospitals before and after the shortage. At the provider level, physicians were significantly more compliant compared to our APPs, which was 48% for physicians, 34% for our APPs, and also compared to our non-APP, non-physicians, which was like our nursing and pharmacist. Trainees, which we defined as fellow and resident physicians, had lower compliance compared to our non-trainees, our attendings. However, there were a very low number of trainees placing orders, so we couldn't make too much of this. At the patient level, factors that measured increased acuity, which were KDIGO scores for kidney dysfunction and SOFA scores, all found that with higher acuity had lower alert compliance. We also found with abnormal sodium levels that we had a decrease in compliance. Patient age and race did not affect compliance. Next, we performed a mixed effects logistic regression model to account for any confounding variables. In this figure, you can see that like the unadjusted model, the ICU had significantly lower odds ratio of compliance compared to the ED. APPs and other providers had lower odds ratio of compliance when we compared them to the physician. And similar to our unadjusted analysis, we found hypernatremia, which was an abnormal sodium level, and higher SOFA scores were all associated with a lower level of compliance rates. But after multiple adjustments or multiple corrections were made, we did not see this, so as a trend and not full significance. To better understand the confusion around the alert, we looked at the order level compliance. That's when we grouped into that 15-minute window. Overall compliance at the order level was around 48% compared to 40% at the alert level. 85% of our windows contained only one alert, which means that 14% included multiple alerts collapsed into that 15-minute window. The adjusted order level compliance factors was similar to that of the alert level compliance, with APPs having a lower odds ratio of compliance compared to our physicians, our ICU lower compared to our ED, and hypernatremia compared to the normal range. Alert interactions are complicated and not well defined in current literature, so there is great value in understanding all the decision points so we can understand and improve on aspects that contribute to non-compliance. There is very limited information on canceled or dismissed CDS, and therefore we cannot compare our study's alert dismissal rates to others. However, we all felt that 26% or over a quarter of our alerts being canceled was a high enough number that we had to evaluate that further. We did this through our order level analysis to see if ultimately compliance was achieved. We had an 8% increase in our compliance rate during that 15-minute window when it was collapsed, which suggests that there was a level of confusion with the initial alert that was eventually overcome. Almost all the alert interactions received an order within 15 minutes. We understand that this could have led to a delay in care and could have left our clinicians confused and or frustrated with the multiple attempts to place an order. And it could ultimately contribute to even greater alert fatigue. We tried to mitigate any confusion with the alert by providing the virtual training and the emails, followed by, we did do emails for the first episode of non-compliance, just to help a better understanding of the study. In the future, a future study that would interview clinicians with high rates of non-compliance could hopefully help provide insight on how to improve an AI CDS. And then one of our last things we did, we wanted to compare our AI CDS to the traditional CDSs. There was a large meta-analysis of over 60 traditional CDS studies that found about a 34% compliance rate. So our rate of compliance was moderately higher than that. which was encouraging. Our study had similarities with traditional CDS, which found that as a patient complexity increases, compliance decreases. This suggests that to be successful, an AI CDS should first target those lower complexity patients with the goal to create a foundation of trust in AI recommendations before implementation into the higher acuity situations. The ED may be a better place compared to an ICU or even the floors to roll out an AI CDS due to the less context that the clinicians have at this point to make any decisions. And so just a big thank you to the Precise Trial team. Here's some of our teammates at the conference in SCCM. And here's my references. And I'm happy to answer any questions and go back to any of the slides.
Awesome. Thank you so much, Danny, for a fantastic talk and I think really interesting deep dive into the how the ADS actually gets out and how people are actually thinking about it. Again, a reminder for everyone to put Q&As into the chat. And I have a question to start off with too.
Sure.
Um, I that example that you gave with the person within like 15 minutes, like
Oh,
opening the
yes.
order, canceling it, opening it,
Yeah.
canceling it. I could just totally imagine someone being like, what is going on here? You mentioned that you did some like education sort of
Mhm.
before the order was rolled out. Could you just talk a little bit more about that? And, did you get a sense of how many providers you were able to reach through that? Or, I know not everyone's always on the same schedule, things like that.
Yeah, so we did every department meeting. So we hit all the ICUs and EDs. It was quite extensive and it was just a 5-minute overview and they had time to ask questions. We tried to keep it short and sweet.
Mhm.
And we had the physicians were on there and the APPs were on there. We do know there was some nursing staff that placed orders for their physicians or pharmacists. We did later go back and reach out to our pharmacists, but they were on the later side. It wasn't the initial education plan. Um, most of our orders were placed though by our physicians and APPs. So that was our first thing. And then we sent out an email, and I sent out an email to every individual person so that we knew that was in the ED or the ICU for APPs and physicians to hope that if we missed them at their department meeting, that we would then catch them at least in an email. We do realize we get a ton of emails. These were probably overlooked, but we did our best by trying to email them individually instead of doing a group email. And then we followed up with those individual emails to people and just saying, do you have any concerns? I would say I probably got 20 responses of people saying, like, I have a concern, or this is why I did it, wanting to explain it. That was the one downside to the alert we did. They couldn't put in a reason why they chose not to be compliant.
Mm. I see. That's yeah, that's super interesting. Makes sense. I can see like sodium, I feel like being one, but otherwise I feel like I'd be like, sure, lactated ringer sounds good. All right, so there's a question in the Q&A from Chris Liston who asks, did you consider assessing overall CDS compliance across CDS tools at the user level? May help stratify users who are generally reluctant to engage in CDS tools.
So you mean not just the one from this trial? Is that what he's saying?
I
Like just
think
CDS overall at Emory?
at Emory, yeah, or if you have a sense of like in general's compliance around like 50% or much lower, because then your trial would actually be pretty good.
I don't know that number for Emory. We could pull that number. That's actually a great point. We know just like what other trials have had, and the highest I saw some as high as 50%. Most of those for CDS, though, were looking at decreasing their number of CDS and seeing if their compliance rate went up. I think one of our biggest challenges for anyone who's a clinician, if every time you place an order, it seems like there's a CDS pop up at some point saying an allergy or based on this condition, do you want to consider something else? And so making ours different or stand out was hard. And so I think that's why they do see those higher rates when you actually decrease a lot of the CDSs. But no, great point. We should actually compare it to all the CDS to see what our rate is. I actually love that idea.
Yeah, maybe you guys are the best, most favorite
Yeah.
CDS. And then I have another question. Now, sort of having gone through it and knowing what you do and sort of seeing the those kind of timelines where people are opening and closing, would you change anything in how you designed your CDS for if, if you were designing it again from the get-go?
I think the one thing it would be nice, you couldn't do it with the CDS we used in Epic. There's only a couple different formats that you can use, but
Hmm.
having them be able to do even a drop down of saying why they chose not to comply would be really helpful. I don't know. I can also say sometimes I just check the first thing, so I don't know if that would be as helpful when it's like you have a drop down box that says like not the different reasons you're not complying. But that's the one thing we're like, we'd love to know why they're not being compliant. We were very
Hmm.
surprised that like as the Kidego score got higher or SOFA score got higher, the thought would be maybe they'd be more compliant, and they were not. So it would be nice to have that information.
Yeah, no, that's so interesting. I'm surprised as well because I think of the interventions in CDSs that we get barraged with, lactated ringers versus saline is like I'm kind of like, most days I don't mind if anything, airing on LR. So similar, I was surprised that it's still kind of around that halfway mark. Yeah, great work to you, great work to the whole team. I know it was really it's really awesome to see you guys doing this study of the algorithm in a true sort of like trial format with all the rigors that are associated with it rather than just jumping to deploy stuff. So really commend you guys and the whole team on that. Looks like I think you probably just answered everyone's questions already in your talk. So I'm happy to give everyone some time back in their day. Let me just also remind everyone that this is our last AI Forum for Health for this academic year. There will be a survey sent out to kind of gauge what people thought of the series and if there's any requested talks for next year as we look to putting together the schedule. We will be on break for this summer, but we'll see you guys back September 18th at the next AI for Health forum. So stay tuned for that. Feel free to reach out to me or Dr. Law with any questions in the meantime, or if you have specific speakers you'd like to see. And yeah, thank you again so much, Danni, for coming and updating us on really important, like detail-oriented evaluation of this. And thank you everyone so much for attending, and hope everyone has a fantastic summer.
Thank you.
Thank you, everyone. Happy Friday. Have a good one.